Good morning po to all our media partners at sa lahat ng one at one ang nanonood sa ating DOH platforms. Welcome to our Kapihan session on primary care. Ako po si Dr. Laura Calio Renegado mula sa Kagawaran ng Kalusugan, ang inyong lingkod sa araw na ito. Noong nakaraang linggo po, matagumpay nating nailunsad ang Primary Care Day. At sa pamamagitan nito, naipakita at naiparamdam natin sa ating mga kababayan, beginning with Pampanga, kung ano ang primary care, bakit ito mahalaga, at bakit kinakailangan ito ay ating matutukan sa pagpapaigting ng ating health system at sa pagpapalawig ng ating mga serbisyong pangkalusugan. Alam natin na ang primary care ay napakahalaga sapagkat sa pagsulong natin nito, sinisiguro natin na ang ating mga serbisyo ay health promotive at preventive in nature. Ibig sabihin sa primary care, mas pinofocus ang pag-detect at pag-manage ng mga sakit bago pa ito lumala at mangailangan ng mas mataas na antas ng pagpapagamot. Upang mas mapalawak pa natin ang pagbabahagi ng kaalaman tungkol sa primary care, we have with us today Dr. Antonio Dans from the National Academy of Science and Technology, Mr. Christian Nuevo of the Philippine Health Insurance Corporation to tackle health financing reforms, and our very own Head Executive Assistant to the Officer in Charge, Ms. Laura Saison. Before we start our discussion, here are some house rules to ensure smooth flow of the session. To ensure the smooth flow of this session, everyone is encouraged to use the naming convention below for Zoom usernames to ensure proper acknowledgement. For example, name, -organization/media outlet. Pay attention to the discussion of our health experts and resource persons. Keep our microphones muted while speakers are discussing and presenting. And also, should you have queries, participants shall signify and send questions in the Zoom's chat box and wait for the host to acknowledge them. There shall be an open forum after the discussion. Submitted questions will be addressed first by our experts, followed by Zoom chat box questions. Every participant is advised to reserve questions. Only questions related to the topic will be entertained. Join the meeting until the last part of the session. Before we start our discussion, mahalaga pong ma-address natin ang mga katanungang tulad ng bakit nga ba mayroong primary health care? Or bakit nga ba mayroong primary care? Ano ba ang mga adhikain ng primary care? Ano ba ang mga agham at ebidensya sa likod ng pagbuo ng primary care? Now, to shed light to these questions and to start our discussion, please welcome Dr. Antonio Dans to discuss the science behind primary care. Dr. Dans, good morning po.
Morning, everyone, and thank you, Laura. Allow me to share my screen. So my short talk will be on an overview of primary care. What is it? Why do we need it? And how do we get going? Some conflicts of interest declarations lang. I'm a general internist and my main practice is primary care. So wag kayong magulat kung papahalagahan ko ang primary care. I'm also the founding president of the Philippine Society of General Internal Medicine, which is an advocacy group for primary care. I'm the lead investigator of a pilot study on primary care, the Philippine Primary Care Studies, and convener of the Philippine Primary Care Coalition. So wag ho kayo magulat kung binibigyan kong halaga, pero talaga namang mahalaga ang primary care. So I'll start with what it is, why we need it, and then talk about a general map used in other countries on how to get to primary care. And then I think Laura and Ian will talk about the local plans, no? So, ito hong pinakamadaling intindihin na explanation ng primary care, no? Para sa akin, kung dagat ho yung healthcare, no? Isang malaking dagat, pwede nating hatiin ang dagat na yan into different parts, no? Pwedeng vertical, mga bahagi ng katawan. Mula ulo, neurology, sa mata, sa tenga, sa baga, gastrointestinal tract. So, we can divide it vertically. Ang problema ho sa vertical or specialty-driven division, bawat tayo, 10 ang doktor natin. No? May doktor sa mata, sa tenga, sa ilong, sa baga, sa kaliwang braso, sa kanang braso. It can get really absurd. So, administratively, a better way to divide healthcare is horizontal. Yung primary, secondary, and tertiary care. So, yung primary care, ano ba yan, no? Ang primary care, yan ho yung mga nagso-snorkeling, no? Snorkelers. Mababaw ang langoy nila, pero malayo. So, malawak ang natitingnan nilang mga sakit mula ulo hanggang paa. Pag kailangan ng specialty care, yan yung secondary care, no? So mas malalim ang langoy nila sa bawat specialty, pero hindi malayo, no? Malalim pero hindi malayo. Ang tertiary care, ano na yan, kailangan mo ng specialist at saka specialty facility. Halimbawa, heart center, lung center, kidney center. So, mga tertiary care center na yan. So, mababaw at malawak ang primary care. Pero wag tayong malito pag tinawag na mababaw. No? Ito ang mga roles ng primary care. No? As defined in the Universal Healthcare Law, may 4 main functions. No? First contact or unang pupuntahan ng patient for any healthcare problem, no? Sa ngayon nakakalito kasi mahina pa ang primary care system. Hindi alam kung saan pupunta pag nagka-COVID, di ba? Sa ospital ba? Sa barangay ba? Sa rural health unit? Punta na ba sa infectious disease or sa pulmo? So, first contact for whatever condition. And ang primary care is the provider of care for 90% of illnesses. So, very comprehensive. Pag kailangan, they will also coordinate or refer for laboratories, pharmacies, specialty care, or even hospital care or rehabilitation. So, coordinator. And the fourth function, siya yung principal point of continuing care. So, pwede nyo tingnan parang abay o kaibigan yung primary care. Hindi nyo alam kung saan kayo pupunta, sa kanya kayo magtatanong, no? At kadalasan kaya nilang alagaan. I'm going to finish that off by telling you what primary care is not. Okay. It's not about check-ups, no? Kasi kuminsan nagkakalituan na pag na-check up ka na, parang okay na ang primary care. Hindi po ho yan totoo. It's about first contact, no? Ibig sabihin, ano man yung karamdaman mo, pwede ka dyan pumunta. Ubo man yan o severe chest pain, pwede kang dyan pumunta to ask about what needs to be done. No? Siya ang gabay mo sa healthcare system. It's not about priority diseases like hospitalization na pwede nating sagutin lang yung mga priority diseases kasi hindi naman kayang bayaran lahat. Primary care by definition has to be about comprehensive care. Kasi ikaw yung unang puntahan eh. Hindi mo pwedeng sabihing TB lang ang babayaran mo sa primary care. Kasi hindi naman dumadating ang patients na may tatak na TB sa noo. Pumupunta sila for cough. No? And you need to work up before you treat. So, comprehensive dapat yan. It's not general medicine. Yung pagka-graduate mo sa medicine, primary care ka na. Hindi po. Although dito nagiging ganon, in most countries, it's a specialty. You need further training in primary care. Bakit? Kasi hindi siya yung pinakamadaling healthcare. Siya or aralin na specialty. Siya yung pinakamahirap dahil Napakalawak ng dapat mong matutunan para maging primary care specialist. Ang tingin ng iba, primary care lang o sa internist lang ako nagpatingin or sa family med lang ako nagpatingin. Ang tawag namin lang specialist kasi it's always followed by primary care lang or internal med lang or pediatrics lang. It actually leads to better care, and that's the next set of slides I'll show you. Does it really lead to better care? So, bigyan ko kayo ng dalawang kwento, no? Ito si Mr. Jose, nakilala ko sa Busuanga nung nagkaroon ng Yolanda. Pumunta kami sa isang island. He's 42 years old. Meron siyang high blood, diabetes, TB. So, hindi yung bagyo ang problema niya. Ang problema niya, he has not consulted for 3 years from any doctor. And so, we had to give him yung gamot niya for high blood, diabetes, and tuberculosis. Kabaliktaran ng kwento kay Mrs. Rosete, who's 56-year-old from Quezon City, na nagkaroon lang siya ng diarrhea. No? So, na-admit siya ng specialist gastro. Dahil nahihilo siya nung dumating siya, siguro sa lakas ng diarrhea, na-refer siya sa neuro. At dahil may diabetes siya, ni-refer siya sa endocrinologist. At mataas yung creatinine niya, kasi tumataas naman talaga pag dehydrated ka, ni-refer siya sa nephrologist. Sinumpong yung gout niya nung naka-admit siya, so ni-refer siya sa rheumatologist. At yung ECG niya may ischemia, ni-refer siya sa cardiologist. Ang ginastos niya po for diarrhea is around 350,000 pesos. At yung kanyang isang anak, tinanggal from school for 1 year to pay for that. So, yung dalawang sitwasyon na to, Mr. Jose has too little healthcare and Mrs. Rosete has too much healthcare. At hindi yan iisang experience ng ilang tao lang, no? Experience yan ng marami. 1.5 million Filipino families a year pay for catastrophic health expenses. Yan yung mga gastos sa health na napakalaki that you are pushed across the poverty line. No? You spend more than 40% of your liquid assets. And itong too little care, a recent study we completed showed families in the lowest tertile, the poorest 33%, have a 46% higher risk of death in the next 7 years. So, mas mahirap ka, mas maiksi ang buhay mo. That's because yung mahihirap get too little health care. So, and that's why we need primary care para walang too little at walang too much. Sila kasi yung coordinator. So, bakit ba nagkaganito? Well, kasi noong araw po, noong 1960s, ang karamihan ng ikinamamatay na sakit, acute illnesses like pneumonia and diarrhea, mga infection. Pero nung nasagot na natin yung mga sakit na yan, humaba na ang buhay ng mga tao. So, hindi na, nung humaba ang buhay nila, yung mga sakit nila, hindi na pang admission, pang outpatient care na like hypertension and diabetes. No? At saka, nagkaroon na ng mga tao, dahil tumatanda na ang mga tao, ng maraming sakit. And that's why we need to shift from hospital to outpatient care. Hindi na acute lahat ng illness, marami ng chronic. Hindi na inpatient, marami ng outpatient. At hindi na iisa, kundi maraming sakit sa isang tao. Ano ba ang pakinabang nito? Well, ito, mga studies on developing countries. Dito nakikita kung gaano kalaki ang investment nila sa primary care sa baba, sa x-axis. Ito yung kanilang per capita healthcare expense. Magkano ba ang ginagamit nila sa healthcare of every citizen, no? And makikita mo, the less they invest in primary care, gaya ng US, malaki ang per capita expenses nila, no? At ito namang UK na malaki ang investment sa primary care, napakababa ng kanilang healthcare expenses, no? So these are landmark studies. I'll show you 3. So between countries, the more you invest in primary care, the lower your healthcare expenses in total. Ito naman, study sa United States, mga 50 states. The more primary care physicians you have per 10,000, so 1 per 10,000 dito, 5 per 10,000. Again, the lower your spending per beneficiary in dollars. So nakakatipid po pag marami tayong primary care providers in a certain community. At yung pangatlong study, mas mahalaga pa, pinakita that for every 1 per 10,000 increase in primary care physician supply, habang dumadami yung ating primary care providers, there is a 5.3% reduction in mortality. This is in the US. That's equal to about 49 lives saved for every 100,000 population. So every time you increase the number of primary care physicians by 1 per 10,000 population, you get that benefit, a reduction in mortality and an increase in the number of lives saved. So talagang it is not inferior care, it is better care. And finally, how do we get there? Very briefly lang, ito yung roadmap to primary care. It's a generic roadmap used in some countries. So, recruit, retrain, retain, regulate, reassess. Ano bang ibig sabihin yan? Yung recruit, we need to encourage careers in primary care by increasing recognition of its importance. No? Kailangan natin to, mga abay natin sa kalusugan. Each Filipino, according to the UHC law, should have a primary care provider. And it should be appreciated by the government. Kasi hindi dapat mas mababa ang bayad sa primary care providers. No? It should be recognized by other practitioners and by the people. Hindi sila lang, no? You should be proud that you have a primary care provider. And then, we should retrain them. So, natutuwa ako, maraming scholarships for doctors, nurses, midwives. Maybe we can even think of a master's degree. Iniisip namin sa UP in primary care. And for those na tapos na sa training, we can have training workshops. Ito, I need to underline this, yung barangay health worker professionalization, no? Lagi taon-taon merong bills on that, pero walang talagang na ipapasa na, no? The barangay health workers are our main workforce. Ang dami nating pinagawa sa kanila noong COVID pandemic, no? Sila taga-contact trace, taga-quarantine and isolate. Sila ang humaharap sa may sakit. At alam nyo ba, ang mga sweldo ng mga yan, kung meron man, 1,000 pesos a month or something ridiculous like that. And then we need to retrain, no? Magaling man tayo mag-recruit at mag-train, nakakawala naman. We are the number 1 exporter of nurses and the number 2 exporter of doctors in the world. So how do we retain them? We need to increase their salaries. We need to standardize salaries. Iba-iba masyado. Meron tayong tinatawag na internal brain drain where the public system drains the private system. Ang bababa ng salary ng ating private healthcare system. So we need to standardize the salaries. Sila yung nakukuha sa ibang bansa, no, yung napakababa ang sweldo. So we need to require private institutions to, sila nga yung malaki sumingil, gandahan naman nila yung sweldo ng healthcare workers nila. We also need to standardize benefits like yung pension and others. And we, as I said, professionalize the barangay health workers. I'll just show you a quick study, 2 studies, no, why healthcare workers stay to serve the country and be with their family. A second study, why do they leave? Because they're unemployed. They have a lot of unfilled positions. We have a lot of unfilled positions. So, maraming walang trabaho. If they're employed, they're underemployed. So, ang baba ng sweldo, lalo na yung ating mga nurses, no? Na job order sila. And that's misemployment. There are job orders and casuals. So, they also work in unjust working conditions, no? Their positions, their appointments are politicized. And their Magna Carta benefits are withheld. Also, add ko ito nangyari sa akin. We need to revise the retirement age for healthcare workers. I retired last week. I'm 65. Parang it is programmed disability. Pwede pa naman akong tumulong sa ating healthcare workers. May shortage nga eh. Tapos pagre-retire natin at 65. We need to regulate. Ito, nangyayari na to, and I suppose Laura will talk more about this. Primary care regulation, yung training and accreditation of facilities, uh, yung needed workforce and the health information system. Pero I would like to add, takpan natin yung butas. We need an international treaty on healthcare worker brain drain, no? Pag merong kinuhang healthcare worker like a nurse here, the recruiting country should pay us twice for the money we invested in that person. No, yung ating training is an investment in our health, and tinatanim natin, inaani ng ibang bansa. And that is totally unfair. So they should pay twice what we paid for the education if these people trained in a public institution. Pag hindi natin takpan yan, tuloy ang butas, tuloy ang pagkakulang ng healthcare worker. And then finally, we need to always have our performance measures, no? Hindi dapat ilang gamot ang na-prescribe or magkano ang nagastos. Our performance measure should be yung about the patients. Natuwa ba sila? Are they using their benefits? Nabawasan ba ang out-of-pocket expenses nila? Are they hospitalized less? Do they have less TB? Do they have less disease? And then we should also monitor our healthcare workers. Are they happy with the system? And are they rendering quality care? And finally, administrative outcomes. No? Mabilis ba tayo magbayad? Dahil sa primary care, mas important yan. Maliliit na organization kasi yan eh. Kung minsan, no? Mga clinics and facilities. So in summary, I've talked about what is primary care, why we need it, and how we get there. I'll end with this slide which is from the London Olympics. Alam mo, sa bawat Olympics, pinagyayabang ng host na bansa yung kanilang contribution to health. In London, dalawang pinagmalaki nila, yung kanilang children's books, like yung Dr. Seuss, at saka nila yung kanilang primary care system. So during the parade opening ceremonies, binandera nila ang kanilang primary care systems. So the doctors, nurses, and even the primary care patients were paraded there, no? Kasi pinagmamalaki nila yan. Sana ganun din tayo. Hindi lang natin sila sineselebrate dahil kumikita sila sa bansa. Umaalis sila at sineselebrate natin sila pag balikbayan sila. We need to celebrate those who are here. We need to pay them more. We need to recognize their contribution to health. Kasi at the end of the day, primary care is about people taking care of other people. At pag hindi natin alagaan ang ating primary care providers, ganun na lang ang lagi nating magiging sitwasyon. Kulang tayo ng primary care providers. And anything we write on paper about health plans will stay on paper unless we solve the shortage of primary care providers. So, thank you for your attention. Back to you, Laura.
Maraming salamat po, Dr. Dance. Ang dami ko pong natutunan about primary care. Also, a very important note, a very important message po siguro na nakuha ko dun sa presentation niyo, Doc, ay ang primary care ay about providing the 4 C's. The initial contact, continuous, comprehensive, and coordinated care.
Yes.
So maraming salamat po. Sadyang napakaganda po ng adhikain ng primary care. Ngunit upang lubos na maisakatuparan at maging mas accessible ang mga serbisyong hatid ng reformang ito, importanteng magkaroon din ng financing mechanisms na higit na makakatulong sa mga individual na nangangailangan ng mga medical services. Importante rin na lubos itong maintindihan, lalo higit ang mga pakinabang nito. At para talakayin ito, narito si Mr. Christian Nuevo mula sa Philippine Health Insurance Corporation. Magandang umaga, Sir Ian.
Hello, Dr. Laura. Maraming salamat sa paanyaya na lumahok sa Kapihan niyo ngayong umaga. And of course, an honor always to follow the Dr. Dance. Always a pleasure hearing your insights, Doc. I-flash ko lang yung screen ko, Doc Laura. Ayan. Okay. So, kanina ang dami may binahagi ni Doc Tony sa atin tungkol sa bakit ba mahalaga ang primary care at sa paanong paraan ba siya nakakabuti sa health system ng isang bansa. Lalo na sa konteksto ng Pilipinas na gaya nga ng sinabi niya kanina, karamihan sa mga sakit na dinaranas ng mga Pilipino ngayon ay chronic at nasa level na ng outpatient. At dala na rin ito sa pag-usbong ng teknolohiya at siyensya na mas nabibigyang atensyon at nararapat na serbisyo na rin natin ang mga acute care as they call it. So ngayong nagbabago ang landscape ng health needs ng ating public, ng mga Pilipino, paano natin ngayon ipapasok ang primary care? On a more particular note, how do we then pay for primary care? Paano natin siya babayaran? So bago ko po puntahan yun, gusto ko po munang ipakita ano ba yung nangyayari sa paggastos ng ating bansa sa ngayon on primary care. So dito po makikita natin, this is a study from PIDS or the Philippine Institute for Development Studies back in 2021. Ngayon pinag-aralan po ng PIDS yung claims data ng PhilHealth across a period of 6 years from 2014 to 2019. So approximately mga 50 to 60 million claims po ito na tiningnan. Yan. So kung makikita po natin dito, sorry, nagkamali lang po ng order ng slides. Pero dito po, makikita po natin sa benefit payout ni PhilHealth, karamihan po talaga ay napupunta pa rin sa inpatient. Most still go to tertiary care. Makikita po natin dito that around 90% of PhilHealth payments still go to hospitalization from infirmaries to level 1, level 2, and level 3 hospitals. So yan po yung kulay green dun sa ating graph. But when we start talking about outpatient payments or primary care, yung pangunahing pangkalusugan ng mga Pilipino, nasa around 10% lang po tayo. At karamihan pa po dito sa binabayaran natin at the outpatient level are mostly for treatments. For example, hemodialysis. But when we start looking into actual preventive primary care, ang benefit payout po ni PhilHealth ay napakababa across the period of 5 years. If we take it as a proportion, nasa 0.0001% lang po tayo on the average. Napakababa. Ngayon, marami pong iba-ibang factors kung bakit naging mababa ang payment ni PhilHealth on primary care. At isa rin po yan sa mga gusto nating solusyonan sa mga darating na mga taon following the Universal Healthcare Act. Ngayon, balikan ko lang po yung unang graph na nagkamali po tayo ng order. Pero dito po, kung titingnan naman natin from a larger perspective, from a more macro standpoint, what's happening in the entire healthcare system ng Pilipinas. Kung titingnan niyo po, ganun din yung pattern. Most of the spending is also on hospitalization or hospital care at around 42%. So napakataas din po. And medyo equal po yung nagiging spending at the public and private general hospitals at around 30% each. So yun din po yung mga yung kulay green po natin in the graph. But when we look at preventive care, again, pangunahing pangkalusugan, 11% lang po ang binabayaran ng buong health system natin for preventive care. The remaining 30% po and the remaining 12% are on other goods. So yung mga pharmacies po natin, yung mga diagnostic laboratories, all of which are outpatient as well but separate from our primary care provider. So medyo pareho po yung nagiging pattern within PhilHealth benefit payouts at sa kabuuan na ating health sector. We are still very hospital-centric. A lot of our resources are still poured into tertiary care. Yan. So ano ba yung goal natin? Ano ba yung gusto nating mangyari if we're pushing for primary care? Gusto natin mapalaki yung kulay yellow dito sa graphs natin. We want to increase spending for primary care in absolute terms, meaning sa actual value, dapat mataas yung spending natin sa primary care. And also in proportion, gusto natin hindi tayo 10%, 11%. Kung kaya natin umakyat to 30, 35%, yun ang target natin. So we want to increase our spending for primary care, and you will see that this consequently actually decreases our spending for inpatient care, which is a very important thing. Kasi ang ibig sabihin nun, mas kakaunti ang nagkakasakit. So, yung iba dito na-mention ni Dr. Dance, pero gusto ko rin lang bigyang linaw pa at bigyan ng dagdag na emphasis yung mga points na to. If we look at the experiences of other countries na merong successful na healthcare system, primary care talaga ang core nila. Yun talaga ang kanilang heart in their health system. So primary care is very important because it improves health outcomes. Ang nangyayari sa primary care, bago pa lumala yung sakit mo, natingnan ka na ng iyong primary care provider. So hindi nalalala yung sakit mo at ma-address na agad ang iyong mga pangangailangan pangkalusugan. Meron din siyang what we call overall economic benefits. When people are healthier, people become more productive. And when people are more productive, they can contribute better to the economy. So nakakabuti rin yun. Maiiwasan natin yung mga kailangan umabsent, maiiwasan natin yung mga panahon na kailangan mamili ng isang manggagawa kung magpapagamot ba siya o papasok na lang siya sa trabaho, right? If we have healthier populations, they are better able to contribute meaningfully and productively to their jobs. It also improves health equity. Nasaan ba ang mga primary care providers? Ito yung mga clinics natin at mga rural health units na nasa tabi lang ng mga bahay natin. It's very close to the community and they know the people in the community. So it really improves equity, di ba? Hindi mo kailangan humanap or sumuyod ng mas malayong ospital para lang magpa-check ng iyong ubo, right? And overall, it also improves health system efficiency. Gusto kong balikan yung pinakita ni Dr. Dance kanina na comparison ng dalawang pasyente na nakita niya. Yung isa, ang daming specialista na pinuntahan, diba? At naging mahal yung cost, right? So naturally, when we seek a specialist, iba rin talaga ang rates, diba? Iba ang fees. And when we seek care in a higher level facility tulad ng ospital, mas mataas din ang cost dahil mas mataas ang cost ng pagpapatakbo ng mas malalaking mga pasilidad. So kung magpapacheck ka rin lang naman ng simpleng ubo o sakit ng ulo, diba? Kaya siya dapat ng primary care level. It becomes a more efficient health system. So kung makikita natin dito in the context of the US, it really has shown that people with primary care providers are healthier and are much less susceptible to financial risk kasi hindi sila napupunta sa sakit na sobrang mamahal. So kung titingnan natin sa Universal Healthcare Act, sino ang dapat na nag-finance ng primary care? So sinasabi sa Universal Healthcare Act na kapag population-based service ang magbabayad ay DOH at LGU. Kapag individual-based health service, ang magbabayad ay PhilHealth. So ano ba ibig sabihin pag sinabi nating population-based and individual-based? Ang individual-based health service ay services that we can definitively trace back to one person o kaya mong balikan kung sino yung actual na nabigyan ng serbisyo. Kanino ka nag-administer ng injection, kanino ka nagbigay ng gamot, sino ang humiga sa inpatient bed. Right? So when we talk about primary care, you can actually trace it to the patient. Sino yung nagkonsulta sa iyo? Kanino ka nag-prescribe ng gamot or ng necessary diagnostic laboratory test, right? So it's counted as individual-based. Population-based is kung hindi natin kayang i-trace back sa isang tao, like when we blast health promotion, when we conduct surveillance of diseases, sa ano siya? General public siya nangyayari. So PhilHealth ngayon ang sinasabing main financing agent for individual-based health services, including primary care. At currently po, konsulta ang primary care benefit ni PhilHealth. Yun po ang kanyang main benefit package for this. So the consulta package includes the following. Meron po siyang initial at follow-up consult. Meron po tayong health screening and assessment. Meron po tayong coverage for around 13 laboratory tests and around 21 medicine. So ito po yung current coverage ng consulta benefit natin. Yan. Ngayon, so yung pinakamalaking tanong na sinabing dapat masagot nito is, how do we finance primary care given UHC Act, given the change in context of our public health system na sinabi ni Dr. Dance kanina. So gusto ko siyang sagutin sa tatlong mas maliliit na tanong. So what services are we going to finance? Who are the providers that we should be financing and how should we be financing these? So napakalaga na mabigyang diin natin kung ano-ano mga serbisyo, sino-sino mga takapagbigay ng serbisyong ito at paano ba natin sila babayaran. So una sa lahat ay what services should we be financing? So sa mga nangyayari po ngayon, kung titingnan natin, iba-iba ang kapasidad ng mga public facilities at private facilities. Kung kukumpara natin, di ba, kung may private clinic sa labas ng bahay niyo at ikumpara niyo sa nalalapit na RHU, ibang-iba yung kapasidad. At kung ikukumpara natin yung mga RHUs din sa mga iba-ibang lugar sa Pilipinas, iba-iba rin ang kapasidad. So kung ikaw ay isang Pilipino, pwedeng pumunta ka sa clinic na malapit sa'yo, tapos pumunta ka sa clinic sa ibang lugar, iba din yung serbisyo na makukuha mo. So nagva-vary yung capacity at nagva-vary din yung access. Yung kaninang consulta benefit natin, admittedly, still is very limited. Kakaunting gamot pa lang ang covered noon at kakaunting diagnostic laboratories pa lang ang covered noon. Now, in the future, iba ang gusto nating mangyari. We want to be able to pay for the entire capacity of a primary care facility, right? Dapat meron tayong idea na kayang gawin ng isang primary care facility. Dapat kaya niyang gawin ang A, B, C, D, E, F, G na diagnostic tests. Dapat kaya niyang i-provide ang A to Z na gamot. Dapat ganito ang oras ng kanyang operation. So, ang goal natin ay hindi natin mabayaran yung mga maliliit na listahan ng mga gamot at laboratories. We want to be able to pay for the entire capacity of a primary care facility. So siguro malaki tanong dito ay kung yun ang goal, bakit si PhilHealth ang nararapat na institution to do that? So isa sa mga pinaka-powerful na mechanisms na kayang gawin ng PhilHealth na very unique to the institution is to contract. Right? So kanina sinasabi ni Dr. Dance, when we talk about primary care, it's not just about consultations. It's not just about ilang gamot ang binigay mo. It's actually about quality of care. It's actually about improving people's health. It's actually about the satisfaction of patients and healthcare workers. All of those are outputs. All of those are outcomes. Yung mga outputs at outcomes na yun, kayang ilagay ni PhilHealth bilang terms niya sa kanyang kontrata. Pag nilisensyahan natin ng isang primary care facility o kahit isang ospital, ang sinasabi lang ng DOH ay kumpleto ka sa kagamitan. Pero kung paano mo siya gamitin at paano ka magserbisyo, labas na yon sa ating licensing. PhilHealth ang kaya maglagay nun in the contract. So with primary care financed by PhilHealth, PhilHealth then can say that I will pay you if you reach this level of care. I will pay you if this level of your population is kept healthy. So napakalaking opportunity nun to drive primary care. Second is, who are the providers that we are financing? Sino ba dapat ang pinabayaran natin? If we look at the health system now, around 65% po ng service delivery natin ay private facilities, pribadong pasilidad. So, pero kung titingnan naman natin at the level of the primary care facility, medyo mas nakakarami tayo in terms of our RHU. So this is an estimation po in 2019. We have around 3,858 primary care facilities, most of which are public facilities. So, pero kung babalikan natin, halo talaga siya ng public at private facilities. So kung ganito yung konteksto ng mga providers natin, ulit, bakit PhilHealth? Ang PhilHealth kasi kaya magbayad ng parehong pampubliko at pangpribadong pasilidad, public and private facilities. Kung mga government agencies kasi tulad ng DOH o kahit yung mga LGUs natin, ang pinupondohan ay public facilities. So malaking opportunity din to make sure that there is coverage even in private facilities. Kung titingnan natin ang datos sa National Demographic Health Survey, actually kahit mas kakaunti ang public facilities natin in our health system, karamihan sa mga Pilipino ay pumupunta sa public facilities dahil walang bayad, dahil libre. Right? So nako-congest din yung mga public facilities natin. So if we can actually pay for services in private facilities efficiently, pwede nating i-transition yung ibang mga tao para maiwasan natin ang congestion in our public facilities. Isa pang napakagandang kakayahan ng PhilHealth ay kaya niyang pagdugtungin or pagsamahin ang mga pampubliko at pampribadong pasilidad. So siguro madalas naman nating naririnig, maraming mga facilities ngayon in the country ang walang gamot, walang pharmacy. Diba? So pupunta ka, magpapacheck up ka, bibigyan ka ng prescription, pero lalabas ka ng RHU para bilhin yung gamot mo. Right? Paglabas mo naman, meron tayong around 29,000 pharmacies. This was an estimation in 2019 again, all over the country. Untapped potential. So kayang bayaran ni PhilHealth yan, kaya nang i-contract ang mga pribadong pasilidad tulad ng pharmacies at ipagsama sa mga primary care providers. So it also expands our way of paying for health services by expanding who we pay. At sa panghuli po is yung how do we pay for healthcare services. So ngayon, pag pumunta tayo ng RHU, libre ang mga serbisyo na makukuha. Pero pagdating natin sa private facilities, halos lahat kailangan nating bayaran. Yung mga RHUs naman po natin ay budget-based, meaning pondo siya ng local government. At depende sa priority ng local government, nag-iiba-iba rin ang spending patterns para sa ating RHUs. Mayroong iba na sagana sa pondo, sagana sa resources, pero meron din iba na mas kaunti ang nakukuha. And that naturally affects ano yung kapasidad ng mga RHUs natin. At siguro sa panghuli, maganda rin bigyang emphasis is hiwalay ang bayad natin sa ating primary level facility at sa ating inpatient facility. So napakahalagang puntos po nun at mamaya babalikan natin kung bakit. So predominantly out-of-pocket po tayo sa pribado, public ay budget-based at nakahiwalay po tayo sa inpatient. So pasok ulit ang tanong, bakit PhilHealth ang magbabayad ng primary care as an individual-based health services? Una sa lahat, PhilHealth money is essentially protected money. Ang bayad ni PhilHealth ay sa facility. Ang bayad ni PhilHealth ay para sa serbisyo. Hindi niya technically kailangan makipaglaban sa budget ng isang LGU, right? Kasi po, di ba, kung makikita natin at the national level, may hearings, merong budget process. Ganon din po sa ating LGU. And in a sense, there is competition for the resources. Ngayon, sa UHC Act, diretso ang pondo dapat ng PhilHealth sa ating healthcare facility. So, sigurado tayo na ang pera ay mapupunta sa mga serbisyong pangkalusugan. Kaya rin ni PhilHealth mag-implement ng iba-ibang paraan ng pagbayad. So isa po dito ay yung capitation, for example. So ano ibig sabihin ng capitation? Essentially, ang ibig sabihin po nun ay bawat isang tao ay may budget. So kung babalikan natin yung sinabi ni Dr. Tony kanina, ang kaibahan sa primary care ay pag dumating isang pasyente, wala siyang tatak kung ano ang sakit niya. Pwede siyang dumating ng may ubo siya at may ubo lang talaga siya. O pwede siyang dumating ng may ubo at TB na pala yung sakit niya. Right? So sa pagpasok ng iba-ibang pasyente, maraming tests, yung workup nga na sinabi ni Dr. Tony kanina na kailangan gawin. Most of these are screening tests to assess and to diagnose ano yung pangangailangan ng isang pasyente. So medyo mas mahirap ma-predict kung ano yung mga kakailanganin ng isang pasyente at the primary level. Kaya po capitation works best. Di ba po? So kung meron ka isang clinic na 100 ang sineserbisyohan ng mga tao at bawat isa doon sa 100 na yon ay may 500 pesos from PhilHealth. Ano yon, pooled yon ng isang primary care facility. So kung meron siyang isa na hindi naman nagpa-test dahil healthy, pwede niyang ayon gamitin yung pera para sa ibang tao na mas marami ang pangangailangan. So may mga ganong mekanismo ang PhilHealth na pwede niyang ma-implement sa pagbayad sa mga facilities natin na outside ng budget-based system. Pwede rin ang performance-based system sa PhilHealth. So kung gusto nating mapataas ang numero ng mga batang nababakunahan, actually pwedeng sabihin ni PhilHealth, o sige, bawat batang mabakunahan mo, ito ang bayad ko. So it becomes output-based. It becomes outcome-based. And that's very, very powerful. And lastly, PhilHealth can also link its payment with inpatient facilities by virtue of a network na sa UHC Act din ito. Bakit ito mahalaga? So kanina, dami kong balik kay Dr. Tony, di ba? Sinabi rin niya na one of the most powerful roles of a primary care provider or a primary care facility is to navigate, to coordinate, to say when a patient needs to go to a higher level facility or will need a specialist, right? So kung mapagdudugtong natin ang ating primary level facility at inpatient level facility, mas pwede silang magtulungan, they can work together better to manage the care of a population or a specific individual. So may mga ganong opportunities when we talk about the mandates and the capacities of PhilHealth in engaging our providers. So siguro bilang huli na lang dito, gusto ko lang ipakita ano rin ba yung trends globally. So kung titingnan natin yung levels of care from primordial, ito yung mga syntaxes natin, yung promotive care like health promotion, primary care, secondary, and tertiary. In highly developed countries, iisang institusyon na nagbabayad yan kasi kakaiba rin naman yung setup nila. Madalas ito yung mga bansang mataas ang tax system, ang tax rates at kaya nilang bayaran ito ng kabuuan. Pero sa mga bansa na mas malapit sa atin tulad ng Thailand, ng Taiwan at Indonesia, ganito ang nagiging pattern. Ang kanilang Ministry of Health or ang kanilang local government pays for population-based health services. And individual-based health services are paid for by a special institution like PhilHealth. In Thailand is the National Health Security Office. In Taiwan is National Health Insurance Office, etc. So marami pong global best practices that shows that this system can actually work. That an institution like PhilHealth actually has the best opportunity to pay for healthcare services, particularly primary care. So napakalaking diskusyon, malaman na diskusyon ng primary care, and I'm very grateful na nagkaroon ako ng opportunity na maibahagi din kung paano ba natin gustong marating ang tamang financing for primary care. So maraming salamat po sa pakikinig. Doc Laura, over to you. Thank you.
Maraming salamat po, Sir Ian. Thank you for your presentation at sa overview po ano po ang health financing. Next we now to talk about the ways forward of primary care in the Philippines. Let me introduce to you the Head Executive Assistant of the Department of Health, Ms. Laura Saison. Ms. Laura, good morning po.
Hi, good morning po sa inyong lahat at salamat sa inyong pagsama sa amin ngayon as we geek out on the science behind primary care, no? So, as I was listening to Dr. Tony Dance and my very good friend Ian Nuevo, it really makes sense that we have to shift towards primary care. But ang balik ko din sa mga taga-pakinig natin ngayon or taga-pakanood, if it makes sense that primary care should be the flagship reform of the health sector, why is it na hindi mainstream yung kanyang kahalagahan? Kasi aminin naman natin at sa hindi, okay na, ako yung mag-share ng screen. Thank you. Aminin naman natin sa hindi, when we think of the healthcare system, the first thing that comes to mind would be yung mga bonggang ospital, malalaking ospital. So in the discussion of Doc Tony Dance, he mentioned about the state of our primary care physicians na primary care physician lang. And if we want to have a comprehensive, coordinated care that is being provided to all of us, then tayo, no, we need to be able to demand for this care, and we need to shift the perspective that primary care is not just care or paunang care or lunas lamang, but this is the actual care that we need as we go through the entire span of our lives, no? So won't speak too much about it because I feel like na-discuss na po klarong-klaro ni Dr. Tony Dance at ni Ian, but saglit, how do I share screen? Okay. So UHC and primary care, and why do they bakit sila hand in hand, no? But I'd like to begin first, no. When you talk of the healthcare delivery system or what the DOH can do, it is actually just 20% of the entire needs of a human person, no? So sa ating pangangailangang pangkalusugan, ang factors that affect us in terms of healthcare delivery or access to quality care would be just 20%, no? Napaka-importante that we understand this in the bigger context of social determinants of health, where 80% of other factors affect health as well. If we have access to good food, if we have access to healthy food, access to good housing, access to education, these actually provide a more or a bigger platform, no? A better indication or predictive value as to whether a person is going to be healthy his or her entire lifetime. And so, itong mga bahaging ito, itong 80% na to, while the DOH is not in the lead of these things, we are working closely with the local government units, working closely with other departments na mas may malaking accountability for these other things, no? Ngayon, if it makes sense to go to shift to primary care, no? Posible nga ba? Kasi ang laki-laki ng reforma na meron at ang laki-laki ng kailangan mangyari. We've always been used to a specialist-centric type of care where kapag sumakit ang puso natin, we'd go directly to a cardiologist, not knowing na heartburn lang pala siya, no? Hindi naman pala sakit sa puso yung talagang problema natin. But when you look at COVID-19 and the learnings that we have seen in COVID-19, nabibigyan po tayo ng pag-asa. Bagamat COVID-19 showed us that marami pang pagkukulang ang health system natin, it also gave us hope. Because through it, we saw that yung mga imposible dating mangyari, nagawa naman eh. So in a span of a few months, from one testing laboratory to 340 laboratories, diba? From no isolation units before or isolation beds, nagkaroon na po tayo ng isolation facilities. At napakaganda din po nung nangyari sa Lubao, Pampanga, kung saan isang COVID wing, which is an isolation facility, ginawa nilang primary care facility. Now it's about translating COVID-19 wins into UHC wins. When you talk of the COVID-19 wins, you see how community workers were engaged and mobilized. Ito po yung sinabi ni Dr. Tony Dance, ang importansya po ng ating barangay health workers and barangay health emergency teams. We've mainstreamed minimum public health standards and preventive measures. We've launched vaccinations, no? The OIC secretary did not only do that for schools, communities, but also went as far as reaching the indigenous peoples, the homeless, vaccinating them. We've also established yung COVID-19 referral networks na ang tagal na panahon na because of legacy barriers, we've always been working on a fragmented system kung saan iba ang pagpapatakbo sa RHU, ibang pagpapatakbo sa district hospital at sa provincial hospital. Hindi sila kumbaga nag-uusap or in sync. But with COVID, napabilis po ang formation of a one hospital command center enabled by telemedicine or information technology. And lastly, there was comprehensive COVID-19 benefit packages where the hope was zero copay for those in wards of public hospitals. Essentially, ito na po yung UHC promise. We just have to use this as jumping boards for the bigger UHC reforms. So kung titignan natin, ang daming kailangan gawin, no? Doon po sa sinabing framework ni Dr. Tony Dance at doon sa kailangang financing reforms. Pero napatunayan natin that if we are looking at one or singular vision, which is transitioning to primary care and creating the demand for primary care at our level po, then it can happen. No, we can create market for primary care. And the way to do market creation for my primary care at the Department of Health would be two major things. One is that there is a Philippine Health Facility Development Plan, which provides for the allocation framework. No, this ensures that there will be no duplication of services in areas. No, nung mga unang panahon po, nung hindi pa po ganun kaganda ang transportation, wala pa po tayong madaming mga kalsada, it made sense to create multiple hospitals or clinics that are duplicitous of services, pero general. Kasi mahirap nga namang tumawid ng isla, mahirap pumunta sa kabilang bayan dahil walang pampublikong transportation. But now, it's about creating a network because it's also enabled by transportation and also enabled by the improvements in our information technology and technology in general. The second one is, ito po yung kaakibat na reforma na ginagawa naman po sa PhilHealth, no? So sa PhilHealth po nagpa-approve po sila that there is a specific specific focus team that will create proof of concept for our comprehensive outpatient benefit package alongside yung tinatawag ni Ian na global budget kanina. So bumubuo po sila ngayon ng dedicated team called yung PhilHealth Surge because apart from because we are recognizing that for market to be created for primary care, not only should there be demand for it, but investments from local government units, from the private sector, should be or can be enabled if there is an explicit payer. At dun po lumalabas yung importansya ng ginagawa nila Ian. But alongside creating primary care as our flagship reform, we also are cognizant of the fact that kailangan po binubuo yung sistema, hindi lang primary care. So we're looking into establishing specialty care services in all regions. So this means upgrading the already existing DOH facilities or hospitals in the regions that we have. So that abot kamay din ang specialty services. We have a very strong primary care services. The mission now is very clear, to have very strong primary care services at the level of the community, but also you have capacity to refer them to a specialty care facility so that kung kakailanganin po nila yon, nandoon po ang karampatang medical na atensyon. Pangalawa po is yung tinatawag nating zero co-payment. No? Sa batas, sinabi na kailangan hindi na po tayo nagbabayad sa basic services or sa accommodation. But what is important is we also do this in terms of a realistic cascade of events. So, ang directive po ni OIC Secretary Maria Rosario Singvergere is magsimula tayo na walang karagdagang bayad sa lahat ng pampublikong ospital, at least for our mahihirap na kababayan. So, this begins with looking at the financial situation of our hospitals, beginning with the DOH hospitals, no, because they receive budget, they get PhilHealth reimbursements, plus there's also medical assistance for indigent patients. And along these lines po is creation of healthy settings, because what is important is not just only to address the medical needs of the communities, but to address what is it in their environment that actually is keeping them from being healthy or living a healthy lifestyle, or being able to, or deterring them from accessing the care that they need. So we're looking at it po in terms of partnering with other departments such as DOLE for healthy work, healthy offices, tapos with Department of Education po for healthy schools, so ensuring that the kids have access to not just COVID vaccination, but also other vaccination activities po, and also the right information so that they're able to assess rightfully what keeps and what they should be doing to keep themselves healthy. No? And lastly, yung pinaka-importante po in terms of creating services for primary care specialty services is a strong, empowered and enabled health workforce. So we agree with what Dr. Tony Dance has mentioned, where bilateral agreements should be explored and put in place so that the nurses and other healthcare professionals that we are sending abroad, magkaroon po tayo ng reinvestment patungkol po sa pag-create po ulit ng mga bagong healthcare professionals. So these are the 5 tangible or initiatives to realize UHC at the level of the directives of the OIC-SOH. But of course, beyond this, patuloy pa rin po ang serbisyo at reformang ginagawa ng Department of Health. Gusto ko lang pong sabihin na napaka-importante po ng ating partnership with our media partners sa pag-create ng demand at understanding why it makes sense for us to shift towards a primary care-oriented health system, kung saan hindi ospital ang hinahanap, kundi isang capacitated rural health unit or clinic sa tabi. No? So alongside naman po, ang Department of Health will work with that so that mai-ensure po natin na safe at dekalidad ang mga serbisyong binibigay sa level po ng clinics, RHUs, and at iba pa pong primary care facility. Ikalawa po, we will work with other departments to ensure that we have healthy, adequate, and sufficient workforce, healthcare workforce po, to promote a primary care-oriented system. And I'll open the floor to discussion because most points have been discussed by Dr. Tony Dance and Ian Nuevo.
Thank you po, Ms. Laura. We now open the floor for questions. To start off po, this is for Dr. Dance and Ms. Laura po. What is the difference between primary care and primary health care? And how does primary care in the Philippines compare to that of neighboring and first world countries? Is there a lot we need to improve on or expand?
Thank you, Laura. Can I share, I prepared one slide for that. Pero actually, na-explain na, I think Laura explained it pretty well. But can I share?
Yes po, Doc.
Yeah, so na-unfortunate yung terms primary care at saka primary health care. Pero napakalaki ho ng kaibahan ng primary care sa primary health care, no? So I want to distinguish 3 concepts: primary health care, primary care at saka primary prevention. They are each subsets of each other, no? So yung primary healthcare, broad philosophy ho yan on what affects the health of people. Primary care is a resource for rendering care for people who need medical care, no? And primary prevention is a service. So they're each a subset. So yung primary prevention, ano lang yan, preventive service, kasama dyan ng check-ups. It's just one of the services that are rendered by primary care providers. So it's focused on healthy people. Ang ibig sabihin ng primary prevention, wala pang sakit, iniiwasan natin na magkaroon ng sakit. Yung secondary prevention ho, nagkasakit, ayaw nating maulit. At yung tertiary prevention, nagkasakit, ayaw natin magkaroon ng complication. So primary is preventing disease in healthy people. So example, vaccinations, check-ups, lifestyle advice. Yung naman, primary care, it's a resource. It's a patient's first contact. Yung dinefine na namin, unang pupuntahan mo, taga-bigay ng comprehensive care, coordinator, and principal point of continuing care. So hindi lang siya prevention. Meron din siyang curative aspects of care. Pag may ubo, pag may sipon, pag masakit ang ulo, etc. And then primary healthcare is a entire philosophy na you lessen health inequity. Dapat hindi lalong humihirap yung mahirap. Dapat lahat ng tao universal access, no? May access to healthcare. So it includes public health interventions, universal healthcare, the role of all sectors, no? I think pinakamagandang explanation yung kay Laura. So, yung primary care, nandito lang siya. It's a part of our healthcare, no? Yung primary healthcare, yan yung kabuuan. Improving education, giving people jobs so that they can become healthier, no? Making them stop smoking and moderate their alcohol intake. So ibang-iba ho yung primary healthcare, napakalawak niyan, napakalaki ng parang lahat tayo may role dyan in promoting health through improving socioeconomic factors, the physical environment, and our health behaviors. Primary care is a small part of healthcare, but it's of the overall health, but it's a very important part, no? Kasi natutuwa ako sa mga presentation ni Laura at ni Ian kasi dati-dati binabayaran lang natin yung malapit ng mamatay na nasa ospital. Hindi natin pag-uwi nila, wala na namang pangbili ng blood pressure medicine o paggamot sa diabetes. Ngayon, babayaran na rin natin yung outpatient services, yung primary care services to prevent yung why they were hospitalized in the first place. So, yun yung kaibahan. I hope that's clear, Laura. Medyo mahirap pa. Laging people interchange it, but they're very different.
Thank you po, Doc Dance. Miss Laura, maybe you can add anything.
Yun naman na siya. So essentially, when you talk of primary healthcare, it's a philosophy. Primary care is a service with the 4 C's. No? So we can actually share naman yung difference ng primary care specialty service. So if that's also necessary. So yung diniscuss ni Doc Tony Dance is actually an alma ata declaration of what primary healthcare is. So primary care is a level of the healthcare service, no? It forms part of your primary healthcare, which is an approach to delivering care. So primary care is your first contact. A specialty care naman is what follows primary care. So it's disease or organ specific. But when you talk of primary care is kabuuan. So kaya coordinated kasi dapat hindi naman yung tao, di ba? Wala namang kaalaman dapat din masyado yung tao. Sino ba yung pupuntahan ko sunod? So it's the primary care provider that does that. I think yung importante din lang na kailangan nating i-differentiate is, sa batas kasi meron tayong tinatawag na province or citywide health system. Tapos meron kang healthcare provider network. Ano yung difference nila? So the province or citywide health system, when you talk of the primary healthcare system, it oversees the entire health system. So not only does it look after the delivery of services, but it also addresses the areas that deter or keep a person from being healthy, like access to good housing, access to water, etc. The healthcare provider network is an amalgamation or a group, no, lupon ng mga healthcare facilities mula primary, tertiary, hanggang yung apex natin. So it's mas service driven, specific to an individual. So ito yung continuum of care na tinitignan natin sa HCPN. Primary care is general, secondary specific to an organ, and then tertiary is a higher level of care that requires upstream referral from primary or secondary care. So ito yung mga prinsipyo or values that guide the formation of healthcare provider networks na tinatry nating i-create at the level of the provinces through the main interventions of financing through the team of Ian.
Thank you very much, Ms. Laura. Now, for the next question from Red Mendoza of the Manila Times. How are we pushing local RHUs and clinics to register to PhilHealth's primary care system or the Consulta program? May nagiging issues ba dahil sa naging mga issues ng PhilHealth dati? Maybe Sir Ian can provide inputs on this question po.
Thank you, Dr. Laura, and of course, maraming salamat kay Red for the question. So, yes, I guess I'm going to respond to it directly. Yes, there are historical issues that are coming into play with the rollout of the Consulta benefit. So alam naman natin yun na a lot of the challenges of PhilHealth as an institution has been very public, right? People have been very vocal about it. And that's actually a welcome matter. Diba? It's an opportunity for the institution to improve how it works. So ngayon po, when we talk about the rollout of Consulta, ang mga nagiging steps po ng korporasyon para maparami ating Consulta provider ay una, of course, mas pinaiigting yung promotion and communication about the Consulta benefit package. So it really starts with driving up demand and driving up the I guess interest of our providers to actually put more attention to primary care. So communication, info dissemination, advocacy are being intensified. And second, in the past few months, the consultations, particularly from those providers who are currently Consulta accredited, have also been strengthened. Ano ba yung mga naging karanasan nila with the Consulta benefit package? Ano yung mga naging problema? Ano yung mga parte ng operasyon nila na hindi pa pala nasasagot ng polisiya. And at the same time, we are also talking to those who have not been or are not yet accredited by Consulta. Ano yung mga rason nila? Bakit ba hindi sila nagpapa-accredit? So karamihan sa mga nakukuha naming sagot ay meron talagang mga requirements din yung Consulta benefit na hindi pa kayang punuan ng mga RHUs natin. For example, kunyari kailangan ng information system or medical record para sa mga pasyente. That's a huge investment in information technology. There are certain service components na hindi rin nila mapunan dahil sa kakulangan ng pondo, kakulangan ng equipment dun sa RHUs. So may mga ganong problema pa, mga challenges na nakukuha din ng PhilHealth sa mga consultations, sa mga current Consulta providers at pati na rin sa mga hindi pa na-accredit. So in the next few months, tuloy-tuloy naman po yung mga consultation na to at magta-translate din po ito sa pagbago ng polisiya. We will be updating the policies and how we engage our providers so that we can also expand the number of our Consulta accredited providers. So may mga ganong steps naman po na nangyayari. And of course, there is very, very close coordination with the Department of Health. Lalo po pag pag-uusapan yung mga supply side needs ng mga RHUs natin. So may tulong din po doon ang ating departamento at meron din pong nudge yun sa mga LGUs natin to start investing so that they can also be accredited by Consulta. So may mga ganun po tayong steps na tinatahak upang maparami ang ating Consulta providers. Thank you, Dr. Laura and Red.
Thank you, Sir Ian. Next question is from Caroline Bonkin of CNN. In the previous Senate hearing, it was mentioned that 26 towns still have no doctor. How will primary care be implemented there? And how about in GIDA areas? Maybe Heya Laura can answer this question po.
Okay, so definitely, si OICSOH, Vergere, has a very good heart, especially reaching those who are unreachable. And so what she says as a directive for this, primarily, yes, primary care should be and must be implemented even in areas with no doctors. So this is where facilitated regulatory pathway and risk-based regulatory pathway comes into play. And second, what comes into play as well would be information technology. So we're actually in talks with the private sector when it comes to ensuring that there is internet connectivity in all our RHUs and exploring the availability, at least man lang, ng telemedicine para may paunang konsultasyon ang mga tao sa mga geographically isolated and disadvantaged areas. But alam naman din natin, hindi lingid sa kaalaman natin, that it will also take time in terms of investment, na magtayo ng mga facilities at magtayo ng referral system. But the directive is clear to ensure first and foremost that access is there through telemedicine first. And then, of course, saka natin i-address yung mas systemic issues on maldistribution of our healthcare workers, precisely why we're also focusing and working with other departments in terms of the HRH Master Plan 2040. So these things have been laid there. It's a matter of ensuring that these things happen in a very timely fashion.
Thank you po, Heya Laura. There is a follow-up question from Red Mendoza po. How are we going to ensure continuous primary care services once LGU devolution happens?
Ask Ian to answer that.
Thank you, Laura, for allowing me to answer. Siguro, isipin natin ano ba yung nagiging implication when we talk about full devolution, right? When we say full devolution, actually the entire autonomy to manage, to finance services are now devolved or now are fully at the level of our LGU. So when we talk about municipalities and cities, full devolution to them means they have full autonomy to manage and they have full responsibility to finance primary level services or primary care. Ngayon yung na-mention natin kanina, in the current regime, iba-iba yung nagiging investment or resource outpour ng ating LGUs for primary care. For some who have heavy attention or value primary care, of course, there's more investment. So mas maraming pondo ang kanilang RHUs. But for some areas also, kulang na kulang. And if we stretch that paradigm in a fully devolved setup, mas lalo tayong nawawalan ng control, di ba? In a sense, because they have full autonomy. And I think this is where we see that there really is great potential or opportunity through PhilHealth, right? As we mentioned earlier, PhilHealth has the capacity to contract, to set terms, set performance targets for healthcare providers. At kaakibat nun, pantay ang bayad ni PhilHealth across different areas. Kung sabihin ni PhilHealth, ang capitation ko o bayad ko bawat tao for primary care ay 1,000, lahat ng Pilipino, kung saan man sila naka-assign na RHU or private clinic, 1,000 ang bayad na sa kanya agad ni PhilHealth na pwedeng i-pool ng isang primary care provider or ng RHU or ng munisipyo or ng city. So in that sense, nagkakaroon ng way to standardize the investment, to standardize the resources, and to standardize the performance kahit pa naka-devolve na siya. So there's really great opportunity there. And with the financing managed largely by PhilHealth through its capacities, DOH now can put more attention to regulation, to service standards, to healthcare worker distribution. So mas nagkakaroon din po tayo ng mas malinaw na role delineation across different agencies at the national and the local level. So these are works in transition na mangyayari po sa mga susunod na buwan at mga susunod na mga taon. So I don't know, Laura, if you still want to add anything or good with the question. Thank you.
Okay na okay ang sagot. Ang pinaka-importante dito is the devolution the full devolution does not run in contrary with the or in contrary to the UHC law. In fact, it's about harnessing how we can align it towards a common goal of reorienting the health system towards a primary care oriented one. So if there are monies being flowed to the LGU, how then do you make sure that these are utilized to ensure that quality care is accessed by the constituents of the LGU?
Thank you po. Hey, now, in the interest of time po, we are only to cater one more question. This is from Caroline, a follow-up question po. Paano ang gagawin ng residente kung walang internet connection? How will they reach primary care providers or facilities? Paano rin po yung 30 minutes away ang layo mula sa nearest health facility?
So as mentioned, no, when you talk of the healthcare system, the other aspects of your society also have to work in coordination with what you want to happen. No, so for internet connection, ensuring telemedicine is in place, we're working with the ICT and the private sector, at least for the RHUs man lang, magkaroon tayo ng stable internet connection. In terms of ensuring that there is health facility, again, investments are being encouraged na ilipat mula sa ibang mga bahagi or levels ng ating healthcare delivery system to the health facilities ng RHUs, creation of private clinics, etc. It also makes sense because when you look at the investments, mas malaki ang ginagastos, no? Kailangan capital outlay for hospitals than creating a clinic. Ang pinaka-importante ditong enabler is really an explicit payer. Because if you are to make care accessible or a service accessible, kailangan mayroong explicit kang pagkukuhanan ng revenue. Kaya din fina-fast track nila iyan yung aspects of how to pay for primary care, no? So it's not just about providing the inputs, no, ensuring the inputs are in place, but also ensuring how do you paano mo mapiga yung investments from private and public sectors, no? And that's also by ensuring that meron kang tagabayad. Maybe I can also ask Doc Tony sa kanyang naging experience in terms of putting up telemedicine, no?
Oh, thank you, Laura. Yeah, I think yung napakaganda ng tanong, no? Yung internet, I think is already partially, we're working on it, di ba? Nagkaroon ng signed executive order last year liberalizing satellite access. And then the Philippine Chamber of Commerce and Industry and other institutions are working with the LGUs para they can access internet through satellite na, no? Kasi ang hirap po nung cable highway for internet. It takes a lot of resources and a lot of time. Pero internet by satellite is very accessible in deserts and forests and mountains. So we look forward to better connectivity using that. No? At the same time, we need to teach our healthcare workers, and we did that in our 3 pilot studies in a rural, remote, and urban area, training them how to render telemedicine services. The second was yung transportation. I think transportation needs to become a health expense. No? Kung babiyahe ka pa ng 3 oras para pumunta sa rural health unit, kailangan ma-cover yan. And we did that in our remote site in Bulusan, Sorsogon. It's a pilot study on primary care. We developed a way to validate and pay for transportation services from very remote areas. No? And then lastly, I'd like to add to the question on mga communities without doctors. We should probably also, it's very important, but let's reorient. It's not just meron ba o wala. Gaano karami ba? So kung isa kang doctor for a 50,000 community na ang daming tao, pwede mong sabihin merong doktor. Pero hindi mo masasabing adequate yun, no? Kasi hindi kayang ng isang doktor na yon at saka yung nurses and midwives niya na kaakibat, hindi nila kayang alagaan ng 50,000 people. So we really need to work on improving our healthcare workforce density, no? Yung dami ng doctors, nurses, midwives, and other healthcare workers for every unit of population. Back to you.
Thank you po, Dr. Dance. Now, before we conclude, may we request our experts to give their reminders and messages to our media partners and to the public. Dr. Dance, you may start first.
Sige. I just have a short and ending message. No? Ang primary care, the foundation of primary care is a workforce. No? Ang dami na nating ginawang revision ng ating healthcare system. Centralized, decentralized, no? Global ba ang payment or reimbursement? Ngayon may universal healthcare. Pero despite the national health insurance, parang ganun pa din, lugi pa rin yung mga mahihirap. They use it less. Their out-of-pocket expenses are greater in the studies we recently completed. So, hindi natin malulutas yung problema kung hindi natin address yung kakulangan ng healthcare workers, especially primary care workers. No? They are the foundation of our healthcare system. If we do not solve that problem, UHC is just a piece of paper. It's a new way of looking at the same thing. So we really need to plug up the holes, increase incentives to stay, train people, give scholarships, but also plug the holes. They're leaving and every government we've had for the past 50 years has recognized that problem but not done anything about it. So I think I'm hoping the current government will put its foot down and say, let's grab the bull by the horns. Let's solve this healthcare workforce problem. Otherwise, UHC will be a piece of paper that's nice to look up. Ibang-iba ho kasi yung pananaw sa taas ng policymaker at pananaw sa baba. If you ask the healthcare workers at the front lines, the problem is, ang baba ng sweldo namin, kulang kami, ang daming gagawin. Yan ho yung problema sa front lines. And if we do not solve those problems, then we're just looking at, policies that we cannot implement. Kaya natutuwa po ako that we have young, brilliant minds like Laura and Ian now in DOH kasi they know what's happening at the front lines, and tuwang-tuwa ako sa mga sinabi nila about solving what's not just the system and what's up there, but solving what's happening at the front lines. Maraming salamat for holding this session. It really, I think there's a good future and we can see the horizon. UHC is attainable if we all work on it together. So thank you to DOH for holding this session.
Thank you po, Dr. Dance. Sir Ian?
Thank you, Dr. Laura. So I think if there's anything I would like to emphasize that was actually also unbundled throughout the presentations and the questions that were raised is that the problems really are branching out to things or matters that are beyond health or are actually beyond the capacity or mandate of health institutions. And I think our OIC, Dr. Vergere, has been emphasizing also in the past that a whole of government, a whole of society approach is very important. So when we talk about the problems of mga simple sa baba na hindi ako makasubmit kasi wala akong internet, dahil wala akong computer, etc. Some of the solutions explored before, like for example, digital platforms that allow you to record the information and then just upload it kapag merong internet. One-time upload and then it's absorbed in the system. So there are those interim solutions that have been developed and have been piloted in the past with partner agencies, both public and private in nature. So not all of them have been successful, but we are making strides in being more explorative, right? In engaging other partners, other stakeholders in the agenda. So I think what will be very important right now is for all the partners to have the same voice or champion the same paradigm of pushing for primary care as the main agenda, right? So we know how powerful communication can be and how powerful multiple voices can be. So we thank you very much for allowing us to share also the plans of DOH and PhilHealth, and of course the insights from our experts. And hopefully this helps us bring together a singular voice to the agenda. So there are still some pitfalls, alam naman natin, and I speak very candidly about the experience of the public about PhilHealth. There are still lots to work on, lots to improve. But that's something that can only be successfully achieved if everyone is also striving towards improving institutions. So we're here very much open to all the feedback and the questions, the challenging questions, so that we may also able to really address issues in our sector. So again, thank you very much for the opportunity and for listening.
Thank you, Sir Ian. Hey, Laura.
So the question is primary care only for the indigents? No, primary care is for everyone. So as long as you're enrolled and you are an eligible member of PhilHealth. And what's nice with the Universal Healthcare Law is that it says all Filipinos are members of PhilHealth. So in essence, primary care is for everyone. There are a lot of things that we need to address primarily on healthcare workers, and USEC or Undersecretary or ICSOH, Maria Rosario Singh Vergeres, at the forefront of ensuring that we address the pitfalls, kung ano po yung kailangan i-band-aid solution muna ngayon hanggang sa pinakamas strategic na items. No? Katuwang po natin dito ang DOLE, ang CHED, at ang Department of Migrant Workers. So the agenda is being set on how to move forward, no? Including pala DFA for the bilateral agreements po nung ating mga reinvesting into the healthcare workers po, now production of new healthcare workers. So, yun lamang po. Maraming salamat po sa pakikinig sa amin today.
Thank you very much, our dear experts, and to all of our media partners. Magkita-kita po tayong muli sa susunod na Kapihan session. Maraming salamat para sa Healthy Pilipinas. Thank you, Doc Dan, Sir Ian, hey, Laura, thank you po.